Hi, everybody. A very warm welcome to all of you joining us for this post-Congress webinar, post-EHA, post-ASCO 2024, dedicated to chronic lymphocytic leukemia. I'm Mohamed Moti from the Sorbonne University and Saint-Antoine Hospital in Paris, France. And we are today broadcasting live from Houston, Texas, where it is roughly 2 minutes past 6 a.m. And in order to deliver this post-Congress webinar dedicated to CLL, we have really the top expert in this field, namely Professor Nitin Jain, who is a professor of medicine and director of the CAR-T leukemia program in the Department of Leukemia at MD Anderson Cancer Center. And as we all know, this field of CLL, especially from a therapeutic perspective, has been evolving very rapidly. The biggest breakthrough was like 10 years ago or so with the advent of the first BTK inhibitors, namely ibrutinib. Then more recently, we had acalabrutinib, zanubrutinib, the covalent, non-covalent pirtobrutinib, and many others coming. And of course, the debate about fixed duration versus continuous therapy. And all of this is actually impacting positively the life of thousands of patients, because as we all know, CLL is the most frequent leukemia actually in the Western countries. So Professor Jain has accepted kindly today to give us a sort of a best of ASCO and EHA. It will be an interactive webinar, so please don't hesitate to post your questions, your comments, and we'll have a debate session at the end of the webinar. But for the time being, I'd like to leave the floor to Professor Jain. Nitin, the floor is yours.
All right. Thank you very much, Professor Moti and the IACH group for this kind invite. And as you know, as Professor Moti mentioned, I think a lot of exciting developments have happened in the field of CLL, and my goal is to maybe review 5 or 6 abstracts from EHA and ASCO and try to put them in perspective over the course of maybe next 30 minutes or so, and then we'll have time for question and answers. These are my financial disclosures. So as actually Professor Moti already mentioned, this is actually 10-year anniversary, a decade of approval of targeted therapies in CLL. So the first ever targeted therapy, in terms of the oral targeted therapy, I should say, was ibrutinib for relapsed refractory CLL, which was approved in February of 2014. So we are right at 10-year mark of really the approval, the revolution of targeted therapies in the context of CLL. And as Professor Moti already alluded to, the field has changed dramatically since the last 10 years, right? Back in, a couple of decades ago, chemoimmunotherapy really became the standard, such as FCR or bendamustine rituximab. But then, as we mentioned, ibrutinib came along in 2014, at least for the approval standpoint. And then we have acalabrutinib approved. We have venetoclax, which is a BCL2 inhibitor approved. CD20 antibody obinutuzumab has been approved. PI3 kinase inhibitor, which are not commonly used, and we've already talked about them, are also approved for relapsed refractory CLL. And in the last, 1 year, early part of 2023, zanubrutinib, another covalent BTK inhibitor, was approved, and a non-covalent BTK inhibitor, namely pirtobrutinib, and we'll talk about it, was approved in December of last year. And coming to 2024, in March of this year, Lysocell, which is a CD19 CAR-T, was the first CAR-T approval in the United States for CLL. And then there are many other trials happening with CD20 bispecifics. We'll talk about that. Novel BCL2 inhibitors, novel BTK inhibitors, also BTK PROTACs or BTK degraders, which are really looking promising, and we'll talk about them. So these are investigational strategies which are being pursued. So you can really see the field has moved completely that we're not using chemotherapy for our patients with CLL, and everything I'm going to talk about today is targeted therapies either as monotherapy or in combination. So let's get to the what we are going to discuss today. So I thought I will divide this talk into kind of three different buckets to say, first, we'll talk about a really emerging concept of doublet versus triplet therapy in the first-line CLL. A lot of studies have been done looking at different combination of BTK, BCL2, with and without obinutuzumab. And we'll discuss some of the highlights, including an update from the Captivate trial, a pirtobrutinib, venetoclax, obinutuzumab trial, which I presented at EHA, and also a trial with Zanu-Ven combination for TP53 aberrant CLL. Then very exciting, couple of oral abstracts were presented at EHA with BTK degraders in CLL. And these are very exciting data. Two different abstracts were presented, and we'll discuss those. And then we heard an update of epcoritamab, which is a CD20 bispecific, so CD20, CD3 bispecific antibody, which the data was presented, a large study for Richter's transformation, an unmet medical need, and we'll review that as well. So let's get into the abstracts. So as kind of we alluded to, the field of CLL, we have a continuous BTK inhibitor therapy, which is FDA approved, or we have a therapy of venetoclax plus obinutuzumab, which is also FDA approved, and it's a one-year therapy. But we and many other groups have been working or studying combination of BTK and BCL2. The most, I guess, the advanced example would be ibrutinib plus venetoclax, which many groups have studied, including our group at MD Anderson. And what we saw an update from the Captivate study at the EHA meeting, and they say up to 5.5-year follow-up, and the median follow-up, they report the data is up to 5 years. So what was the Captivate study? Captivate study is the concept of combining BTK and BCL2 together, namely ibrutinib and venetoclax. They had two different cohorts, but let's just focus on the fixed duration cohort, where you get 3 cycles of ibrutinib as a lead-in, and then you get 12 cycles of ibrutinib plus venetoclax, and then you stop therapy. So there is no further therapy beyond 12 cycles in the fixed duration arm, and that's the arm we are going to talk about. 159 patients were enrolled, median age was 60 years, and rest of the characteristics are pretty similar to what you would expect in a newly diagnosed patient who need treatment. And this is the important data slide which they showed. So this is, 5-year PFS they are reporting. And if you look at all treated patients, so these are all patients, the 5-year PFS was 67%. And I will show you some comparative data to place that in perspective, but just remember the 67% at 5-year PFS with this I+V regimen. Now, if you look at the high-risk cohort, which is 17p and mutated p53, they had 27 patients, and there the PFS was only 41%. But if you did not have that p53 aberration, it was impressive at 73%. So again, I would say that this data in my assessment, and we saw similar data at the ASH meeting as well, that the 1 year of I+V may not be sufficient because the PFS is maybe not as impressive as some other studies have reported. Here, the 5-year PFS is 67% for all patients and only 41% for patients with TP53 aberration. We would have hoped it would be better because you're using 2 drugs together, but I think it's a matter of duration of therapy, and we'll talk about that. They also did some nice analysis looking at IGHV status. So patients who have mutated IGHV, they do better than unmutated IGHV. And they also looked at MRD, which is kind of makes sense that if you are undetectable MRD at 10⁻⁴ sensitivity in either blood or bone marrow, after the end of therapy, you do better versus if you're not. So it kind of makes sense. If at the end of 1 year of therapy, you're MRD positive, you're likely going to relapse faster versus if you are not MRD positive. They also looked at analysis at 1 year off therapy. So these are 1 year off therapy, whether you're MRD positive or undetectable MRD at 10 to the -4. And again, they saw the same thing, that if you are, and again, kind of intuitively makes sense, if you have no MRD detectable at 1 year post-treatment, you'll do better versus the patients who do have MRD. Now, how to put this data in perspective? And this is a slide I made. Actually, I had made it after ASH last year, but I updated it with this new data from Captivate. So those who kind of follow this data would recognize there have been several studies looking at I+V. First of all, there is a GLOW study, which is not in the data set, which was older patients who got I+V, and that led to the approval of I+V in many countries, including Europe and Canada, but that is not approved in the United States. But there are 3 other regimens which have been done, including the study from our group, where we did 24 cycles of I+V, so 2 years of I+V, and we saw a 5-year PFS of close to 90%. Then the UK group did a FLAIR study in which they did actually 2 to 6 years of I+V. And here, the 3-year PFS was very impressive at 97%, and we'll look forward to more updates about this data. And then we have the Captivate study, which I just reported to you. We used 12 cycles of therapy, which is also the approved duration of treatment based on the GLOW study. Here, as you can see, the 5-year PFS I mentioned to you previously had drawn down to 67%. So obviously, these are cross-trial comparisons, and the patient population may be slightly different. And I did highlight some of the important aspects you may want to look at when you do cross-trial comparisons. But nonetheless, I think one of the most important factor is the duration here, where I+V is in the Captivate is 12 cycles versus 2 years or 2 to 6 years in the MD Anderson and the UK study respectively. And I think that is what is driving the improved PFS we are seeing in these studies. So I think that just leaves the point, then is 1 year appropriate, or should we be doing more therapy with I+V based regimen? I think that remains unclear at this time, but what the data would suggest is that the longer duration is probably important. Now I want to move to another trial, which I reported from a group at EHA in an oral presentation, which is bringing. We have seen a lot of studies looking at covalent BTK inhibitors with Ven. We just talked about ibrutinib plus venetoclax. There are studies with acalabrutinib plus venetoclax. There have been studies with zanubrutinib plus venetoclax with and without obinutuzumab. But this is the first study looking at pirtobrutinib, a non-covalent BTK inhibitor in the first-line CLL setting. So as I mentioned, pirtobrutinib is a non-covalent BTK inhibitor, and this is the first results, and I think the first results in any disease subset for pirtobrutinib in first-line setting. So this is a trial done at MD Anderson, where we enrolled patients with treatment-naive CLL SLL meeting 2018 IWCLL treatment criteria. Now, this is the treatment design for about 1 year of therapy. So patients start cycle 1 with pirtobrutinib plus obinutuzumab, and then after cycle 1, so in cycle 2, they start venetoclax to a total ramp-up dose of 400 mg. Obinutuzumab drops off after cycle 6, but pirto and ven, the 2 oral drugs, continue up to cycle 13. And the important thing in this trial we did was we measured MRD by next-generation sequencing adaptive assay in both blood and marrow at serial time points. And end of cycle 7 was a primary endpoint, and then end of cycle 13 was another important time point for the study. So here we enrolled 40 patients in this study, in this trial, median age of 64 years. We had 75%, slightly higher than what you would expect of unmutated V gene patients. Among these 40 patients, 1 patient unfortunately came off early during the study due to newly diagnosed head and neck cancer, and it needed treatment for that. But the rest of the patients are still continuing on the study. 39 patients have completed cycle 7, which is the primary endpoint, and 20 patients have completed cycle 13. Now, one thing what you do is when you give pirtobrutinib and obinutuzumab for 1 month before you start venetoclax, we wanted to see if the This combination of peto and obin will downgrade the TLS risk, which people who do CLL will recognize there are specific criteria for venetoclax TLS risk category. And what you can see here, as is highlighted in the box here, majority of the patients had downgrading of their TLS risk category after 1 month of pirtobrutinib plus obinutuzumab, making the venetoclax initiation easier. And this is the main data slide, which is the MRD assessments at serial time points. So here, just to kind of reorient you, the MRD is plotted that the green is undetectable MRD at 10 to the power minus 6 sensitivity. Blue is -6 and -5. Yellow is -5 and -4. And red is what would be traditionally considered at MRD positive at 10 to the power -4 sensitivity. So you can see after cycle 6 of triplet or cycle 7 total, 79% in the blood and 64% in the bone marrow were undetectable MRD at -6 sensitivity. You can obviously plot these numbers to a -4 sensitivity as well, which will be 92% and 90% respectively. And then at month 13, we had 20 patients who have reached that time point, and you can see the corresponding numbers of 10 to the power -6 sensitivity were really very high at 90% of the blood and 85% in the bone marrow. And again, you can plot corresponding 10 to the power -4 sensitivity numbers as well. So numerically, and I will show you towards the end a comparative slide, but these numbers seems pretty high and pretty promising in terms of the depth of remission, which is being achieved for these patients. We did see a grade 3 for neutropenia in 60% and thrombocytopenia in 18% of the patients. About 30% of the patients required dose reductions for mostly neutropenia, and 1 patient developed atrial fibrillation. These were conclusions where what I showed you is very high rates of undetectable MRD6 rates in the bone marrow and blood. And then, when you compare these to our historical standard, and for, as I mentioned, we did a previous trial with ibrutinib plus venetoclax, where we only had data for 10 to the power -4 sensitivity in the bone marrow. But if you just do cross-row comparison, these results are numerically much higher, much better than what we saw with the I plus V combination. And currently, no patient has progressed or died in the study. Our follow-up is just about 1 year. And we currently have an expansion cohort of 40 patients we are enrolling. So one of the questions you will have is that, okay, this is great, but how does it compare to all the other data sets we have known? For example, when obinutuzumab, when ibrutinib, the triplet, Acala triplet, Zanu triplet, and now for the first time, we have the peto triplet. And I tried to plot here MRD rates at about 1 year of combination, either in the blood or bone marrow, which have been reported in different studies. And certainly at -4 sensitivity, we see high rates of MRD4 in the blood, as you can see here, as well as in the bone marrow. But I think the important point in this study, what we were seeing is deeper level of remission. For the first time, we have both blood and marrow looking at MRD6 data, and we are really seeing high rates of remission, which sometimes, if you compare cross-trial numerically, they seem much higher than what has been reported with some of the other studies. So again, it's a ongoing study from our group, and we'll continue to update it hopefully at the ASH meeting. Also, a question arises that, we are seeing neutropenia grade 3 or 4 of 60% and 18% of thrombocytopenia, and how does that compare across the trials? And I think when we plot the numbers, you can see that grade 3 or 4 neutropenia is very common in 45 to 50, 55% range across trials. And again, the grade 3 for thrombocytopenia is also very common, especially in the obinutuzumab containing regimens. So overall, the data, the toxicity profile is similar to what has been observed with others. Now, with these combinations, I think we're really changing the field. But one group of patients where we're still struggling a bit is these patients with del17P or P53 mutation. And the zanubrutinib, which is a BTK inhibitor, has been combined with venetoclax, so 2 oral drugs together, as we discussed. But this trial only looked at 17P or P53 patients. So this is so-called Arm D of the Sequoia trial, where 66 patients receive the doublet of Zanu plus just venetoclax. Again, you start with zanubrutinib first for a lead-in, then you add venetoclax, which can continue for up to 12 to 24 cycles. They treated, 66 patients. Overall, I think an important point here is that majority of the patients are still receiving the therapy. So they have not discontinued the therapy. They're still on therapy, as you will see the PFS curve soon. They kind of nicely differentiated between how many patients had both versus one in terms of the genotype status of del17p versus p53. High rates of remission. And also they nicely report peripheral blood MRD rates at different time points on the study. But I think the very important data site is the PFS. So here we don't have very long-term PFS. I mean, they report only 24 months PFS of 94%, which looks pretty promising. Obviously, an important point with these approaches is, can you deliver a time-limited approach? For example, we talked about I plus V. Can you do a Zanu-Ven as a time-limited approach for del17p patients? And that's something I think right now with this study we'll have to wait for longer follow-up because, as I said, practically everyone is still on Zanu or Zanu plus venetoclax. So they're still on the treatment. It'll be helpful to see what happens at 4 or 5 years of follow-up, which again will be a couple of years down the line. And now I want to move to 3 different abstracts, which are new concepts. So these are new drugs coming in the field of CLL. And these are not your typical BTK inhibitors or BCL2 inhibitors. And the 2 abstracts, which are very, very similar in terms of the data, are so-called, what is called BTK degraders. So these are the compounds, and the first one I'm going to talk about is the one from Nurix, namely 5948, NX5948, and how these degraders work. And these degraders are now coming along actually in a lot of different fields of B-cell malignancy, not just B-cell malignancy, including AML and others as well, where they degrade the BTK protein completely, as opposed to just inhibiting the protein. And this is kind of shows the mechanism of action of these degraders. So the Nurix drug is an oral drug, which in a CLL, they started a dose escalation starting at 50 milligrams daily, going all the way up to 600 milligrams daily. And they have a separate NHL cohort, which will be reported later. They treated 31 patients with CLL and you can see the different dose levels these patients were treated, 50 milligram all the way up to 600 milligram. When you look at these patients, these were heavily pretreated patients, 4 prior lines of therapy. Practically everyone had a prior BTK inhibitor. Many patients also had prior pirtobrutinib. High risk of, high rates of p53 mutation. So these are, tough patient population, 31 patients with 4 prior lines of therapy. And interestingly, when you look at the AE profile, and if you just kind of focus here, except neutropenia of about 19%, grade 3 for neutropenia of 19%, no other BTK specific side effects like no atrial fibrillation or others they reported. So which is very, very good. It's an oral drug. The main side effect appears to be neutropenia, but doesn't seem to have the BTK side effects what we know of. And this is a very, very important slide where you see that practically every patient has responded. This is the lymph node tumor burden reduction, and they're still responding. They're still on the study, except a few patients have come off study, but practically everyone is still on the study. So this is quite remarkable. An oral drug among patients who have practically failed a BTK inhibitor, failed venetoclax, and now you're giving another oral drug, and they're responding so very well. So I think the time will tell. The follow-up is short, but how it kind of pans out. And this just shows that different BTK resistance mutations, such as we know now, non-cysteine 481S mutations, such as V416. They also had a patient with L528W. At least V416, the patient seems to be responding. And there is this one 500W, which also seems to be responding. So the conclusion at this time is that, these oral drug is working very well for this heavily pretreated patient population, and they are now moving towards an expansion phase, and they also will present NHL data and at a later time point. So this is, I think, a very, very exciting data set, a class of drugs called BTK degraders, which I won't be surprised that I think in the next few years, these may actually replace your inhibitors depending on how the data matures with these BTK degraders in the context of CLL, because they're also oral drugs. They degrade BTK completely, and it doesn't matter what resistance mutations you have. So very promising data. And at the same ASH EHA meeting, we saw very similar data with the BiGene drug called BGB-16673. This is also a BTK degrader. They also show how the degrader works. Also, the schema is pretty similar. They go from 50 milligram all the way to 600 milligram. They have treated 49 patients with CLL. Again, different dose levels which have been studied. Again, you see these patients where they have 4 prior lines of therapy, so very similar to the Nurix compound, where also they had 4 prior lines of therapy, and practically everyone has received BTK inhibitors, and many patients have also received non-covalent BTK inhibitors. If you look at the AE profile, actually very similar, 20% neutropenia, grade 3 or 4 neutropenia rate, which is exactly the same, 19% in the Nurix trial. So two drugs are very, very similar. It looks like in terms of the AE profile, in terms of the patient population they treated. And when we look at the outcomes, this is overall response rate, 72%, very similar to the previous data set with Nurix. And similar to that, if you look at all the patients as the swimmers plot, you can see majority of the patients are still on the study. They also plotted out some of the patients with resistance mutations. But the important point here is short follow-up, but again, majority of the patients are still on the study. So expectation with ongoing therapy, the response may deepen. So similar to these other BTK degraders, this study, they're moving into phase 2 data as well as combination therapies in earlier lines of CLL. So very exciting data with these 2 BTK degraders. And then there are other companies which also have BTK degraders, which have not been publicly reported, but hopefully we'll hear them at ASH meeting. And my last quick slide is looking at a different mechanism of action. So this is a drug called epcoritamab. Now this is approved for non-Hodgkin's lymphoma, but it has also been explored both for CLL as well as for Richter's transformation. And what was reported at EHA was the data with Richter's transformation. So epcoritamab, as many of you know, is a bispecific antibody. It targets CD20 on the tumor cell and CD3 on the CD3 on the T cells. And it's a subcutaneous, it is given subcutaneously. So this trial has a 42 patient cohort of Richter's, which is a large patient of Richter's patients who are treated. And again, the drug is given in a step fashion, and the target dose is 48 milligrams subcutaneously. They treated 42 patients, and it's important that they treated a mix of frontline Richter's and relapse Richter's. So half of the patients had prior therapy for Richter's. The remaining half of the patients had no prior therapy for Richter's, but they had prior therapy for CLL. And when they split the responses among 20 patients with first-line therapy for Richter's versus second-line, 60% versus 44%. So decently high rates of remission without chemotherapy, especially in the frontline setting, which is encouraging. They also plotted the PFS curves by responder versus non-responders, which kind of makes sense because if you don't respond, your PFS will be less. I wish they had separated the PFS curves by first line versus second line and beyond for Richter's, just to get a sense, which they did not. But just trying to show that there is some durability of these remissions. And now if you're using any bispecific antibody, whether, for example, original one, blinatumomab for ALL, or many other bispecifics now approved for DLBCL, you can see that CRS mostly were grade 1 and 2, though 5% had grade 3. and the neurotoxicity was mostly grade 1 and 2, but it's an important clinical consideration if you're using bispecifics in your clinical practice. At this time, they're exploring this in both in CLL, where they're combining it with venetoclax, and for Richter's, they're combining with R-CHOP as well as with lenalidomide, and those trials, those cohorts are kind of ongoing. So I think hopefully in this 30 minutes or so, I talked to you about some new doublets and triplet data in CLL. We talked about the Captivate study, which shows a 5-year PFS of 67%, but raises the question, what is the appropriate duration of I+V? Should we be longer than 1 year? I showed you data for the PVO trial from MD Anderson, where really we are seeing high rates of MRD6 remission in both blood and marrow, and very encouraging data. I showed you data with Zanu and Ven, especially only for P53 aberrant CLL. The data is quite encouraging, but I think we need longer follow-up to kind of make a point that could you use a time-limited approach for a P53 aberrant patient? The BTK degraders, I showed you 2 data sets, one from Nurex, one from BeiGene. Both are very active and appear not to have BTK-associated toxicities, with the caveat that the follow-up is short, and sometimes these become more apparent when the patients have been on drug for a few years. And there are combination studies planned with these BTK degraders. And then the upcoratimab data, a bispecific in CLL in Richter's, is promising, especially in frontline Richter's. And if you could develop a strategy without chemoimmunotherapy, which will be very, very helpful for patients with Richter's transformation. All right, so with this, I would like to conclude, and we'll go back to Q&A session. Thank you.
Thank you very much, Nitin. Really beautiful and very nice, very well-structured summary. You gave us in 30 minutes, I think, the best of these recent congresses. So we have a lot of questions. So if you allow me, I'll try to make a selection. First of all, we have, and this is coming from a low and middle income country, we have a lot of colleagues across the globe who don't have access to all of these targeted therapies. So the question here, which has come several times, is about, is there still a room for conventional chemotherapy in CLL? And if yes, for which group of patients?
Yeah, so, I think this is a very obviously appropriate question. And historically, chemotherapy, obviously we were doing chemotherapy forever up until a few years ago. But during this time, I think it was clear that there is a group of patients, younger patients, less than 65, who have mutated IGHV, who do not have P53 deletion, P53 mutation or deletion 17p, which is the group of patients so-called have been said to be cure fraction or cure after FCR therapy from our group, and some other groups have also stated the same. So that's the group of patients where, I think if we have to use, that's a group of patients one could consider chemoimmunotherapy if, again, access to novel therapies is an issue. Having said that, we have data now from the ECOG trial and other trials where even for mutated IGHV patients, BTK inhibitor-based therapies are superior for PFS compared to FCR. The FLAIR data from the UK, which was in New England Journal at the time of ASH, showed I+V compared to FCR, both PFS and overall survival improvement for I+V, ibrutinib plus venetoclax versus FCR. So certainly if cost is not an issue or it's covered and it's manageable, there's no question that target therapy should be used and there's no role for chemotherapy. But if obviously it's not affordable, accessible, what can we do in that situation? It's tough, but you have to rely on chemotherapy. But I think one group of patients would be the one I mentioned, young patients with mutated IGHV, who would benefit more from chemotherapy than other subgroups.
Thank you. I think that was a clear answer, and I hope the colleagues were happy with this answer. Another question we have is about the potential pro and con parameters for covalent versus non-covalent BTK. Where do we stand today?
Yeah, so So certainly how the development has happened appropriately is that we had covalent BTK inhibitors for the last, 1 decade. And the non-covalent BTK inhibitor, which really is pirtobrutinib at this time, at least approved setting, was just approved, 6 months ago, 7 months ago. And we know activity of non-covalent BTK inhibitor, namely pirtobrutinib, after you have failed or you are intolerant to ibrutinib, acalabrutinib, or zonabrutinib for that matter. So, and that's where the drug is approved. So certainly there is ample data of using pirtobrutinib post failure of a covalent BTK inhibitor. Now, pirtobrutinib is now being explored in earlier lines of therapy, including in frontline therapy in phase 3 studies. The data I showed you was our own internal study at MD Anderson, which is a phase 2 study, but there are other larger phase 3 studies ongoing. And if they are positive, it may eventually lead to approval of pirtobrutinib for frontline setting. And then the question will arise, you're using your non-covalent BTK inhibitor, namely pirtobrutinib first. What would be the activity if you were to use then later drugs such as acala, zanu, and ibrutinib? And that's something we don't know right now. So I think time will tell, the data will emerge, hopefully, clinical data. But I think certainly we know the safety of non-covalent BTK inhibitor, which looks pretty promising. And that was one of the reasons we wanted to try investigate that for our frontline patients with CLL. And we're also using time-limited approaches. All trials these days in CLL are really looking at time-limited approaches. No one wants to have a 10-plus-year therapy of a BTK inhibitor. So, and when you use time-limited approaches, you lead to less resistance because no one progresses when you're getting a 1 or 2 year of therapy. Practically, even progresses later on, and you can retreat them if you need to be. So, an evolving area, but I think ultimately the time will tell if you can use non-covalent BTK inhibitors first and then sequence them later with a covalent inhibitor.
Thank you. I agree with you. And actually, indeed, the recent advent of pirtobrutinib has been very welcome, and the safety and efficacy profile are really great. We have another question about MRD negativity. And the question is, should MRD negativity become the goal for all patients, and can we use it to guide the treatment, especially treatment discontinuation?
Yeah, so MRD in CLL is an ongoing and evolving discussion. Because an argument. So obviously, we know MRD works fantastic in myeloma, fantastic in ALL, in AML. In CLL, the thing with MRD is that there are drugs which work fantastic without patients becoming MRD negative, namely BTK inhibitor. If you use ibrutinib, no one will become MRD negative. I don't even check for MRD if a patient has a single agent ibrutinib because maybe it's not really helpful. Now, some could argue it may help, but in general, it doesn't really help. But I think multiple data sets have shown that if you're using a time-limited approach, for example, when obinutuzumab for 1 year, or for example, when ibrutinib, or doublets or triplets, and you stop therapy at a certain time point. And if you're MRD positive, and when I'm saying MRD positive, most of the data is with 10 to the minus 4 flow cytometry, intuitively it may make sense. If you're MRD positive, you still have some disease, you will likely to relapse faster than versus not. I think in CLL, an important aspect is IGHV status, because if you're IGHV mutated, you could do relatively well even if you're MRD positive, but unmutated, and if you're MRD positive, you will really relapse very, very fast. So that also needs to play in part as well. Practically all trials, all registration studies right now are looking at time limited, like it's 1 or X duration of therapy. They're not looking at MRD guided therapy because first of all, it's a bit tricky in terms of the approval process because MRD done by flow cytometry is not uniformly standardized. And FDA is quite, they want a standardized assay if you want to approval based on an MRD. Multiple myeloma groups recently had this big FDA effort, and they are, which led to the, MRD being recognized as a surrogate. And I think similar efforts are being planned right now, actually, in the context of CLL, but we'll see how they pan out. So I think but in my clinical practice, if you were to ask me, yes, I do use MRD to make treatment decisions for time-limited approaches. It may not be too much data-driven, but it's just maybe some, clinically experience kind of driven.
Excellent, thank you. Another practical question, are there any specific patient characteristics that would push you to favor acalabrutinib versus zanubrutinib or vice versa?
Yeah, so just to kind of to clear a background, I think ibrutinib has really fallen out of favor as a single agent therapy for patients with CLL because of the toxicity profile, and the two randomized studies in relapsed refractory CLL. Both showed one acala versus ibrutinib, one zanu versus ibrutinib, and both showed better safety of second generation BTK inhibitor, and the one with zanubrutinib also showed better PFS versus ibrutinib. So based on those phase 3 studies and even the phase 2 data previously was quite positive in that regard, many clinicians, including our group, we have stopped using ibrutinib for our patients. So then the question becomes acalabrutinib versus zanubrutinib. Which would I use? And I would say in my practice, again, I don't see that there is one clear-cut answer here. I think both are excellent drugs. They've never been compared head-to-head. They will never be compared head-to-head. So I think it may depend on just the experience the particular physician has with the use of these drugs. Now, there are some side effects with acalabrutinib. You can get headaches early on in the first month, which could be a factor. But again, most patients do okay, and caffeine helps, and it generally goes away. It's not a major issue. There may be slightly more neutropenia with the zanubrutinib, but again, not a major, game changer in a way, or deal breaker in a way. So to me, both drugs are really fantastic drug, and I use them kind of, both of them in my clinical practice.
Wonderful. I'll take for the last 1 or 2 minutes one question, and this is about where do we stand in CAR T cells for CLL?
Yeah, good question. And I did not include any slides specifically on the CAR T cells, just because there was no major update at the meeting. But, CAR T cells, namely Lysocell, was approved in March of this year, just a few months ago. So this is the first CAR T approval for CLL. It is approved for patients who had prior BCL2 inhibitor and a BTK inhibitor. The data, I would say overall, compared to non-Hodgkin's lymphoma, where it has been approved for many, many years, ALL, which has been approved for many, many years, and myeloma as well, where, the data, the response rates are many times 70-80%, at least in the lymphoma world and ALL world. The response rates, the MRD rates in the blood was about 60%, and MRD rates, I'm talking about 10 to the minus 4 sensitivity, in the bone marrow was about 50%. So numerically a bit lower than maybe what we would have wanted, what we had hoped for. And if you look at the PFS for so-called double exposed patients, the median PFS was about 12 months or so. So I think, it certainly works well for certain patients, and certain patients I'm sure will be cured, a small fraction, after receiving CAR T cell therapy, namely Lysocell. But majority of the patients will eventually either do not respond or will relapse after a response. So I think more needs to be done in terms of the CLL CAR T strategy, whether it's a better autologous CAR T products, whether you combine with the BTK inhibitor, for example, with ibrutinib, or for example, with second non-covalent BTK inhibitor, or you look at allogenic CAR T cell therapy, because those autologous CAR T cell therapy, autologous T cells are dysfunctional. We know this is historically has been known for a long time. Patients with CLL, the T cells from patients with CLL are dysfunctional with high PD-1 and immune checkpoint expression. They're exhausted. And so it may be better to use a donor T cells, allogenic T cells, which are healthier. But again, that field of allogenic CAR T cell therapy has not really panned out that well so far, at least in many different disease subsets. So, but I think more needs to be done. But certainly it's an approved strategy in the United States, and we're starting to use it now for our patients with CLL.
Okay, thank you, Nitin. That was really a wonderful summary, and the acceleration of innovation in CLL is quite amazing. similar to what we see in other hematologic malignancy. And this is really good news for the patient. So I'd like to thank you for taking the time to do this summary, Nitin. I'd like to thank our audience. And you may have noticed that we slightly modified the timing for these post-Congress webinars this month to allow our colleagues in Asia and Australia to be able to connect in a decent time. So we're trying to cover the maximum time zones. Of course, all the webinars will be available on demand, and you can, of course, view them. But for the time being, I'd like to thank you all. I'd like to kindly remind you that during this week, we have tomorrow the myeloma post-Congress, Wednesday, the post-Congress dedicated to MDS and acute leukemia. We have the Journal Club also this week, and we have a roundtable discussion also dedicated to relapse refractory myeloma. So you can see plenty of post-Congress activities brought to you by the ICH around the globe and across the hematology field. See you soon.
Thank you.